We often are presented with a case of a patient who's undergone neoadjuvant chemotherapy, and despite either dose-dense MVAC or gemcitabine and cisplatin, they have residual disease, either positive margins, infiltration into the fat, positive lymph nodes. So Dean, what about the use of immune therapy in this situation? What's known and what's not known?
So we're at the exploratory stage right now, but trials are ongoing. So let's take a look at that population of patients who have neoadjuvant chemotherapy and then they have residual muscle-invasive disease, either PT2 or node-positive disease. They've had their cystectomy and their pelvic lymph node dissection. We know from modeling those patients, in fact, and in even doing a prospective trial looking at a dendritic cell vaccine with HER2, that the median time to progression or recurrence of disease is about 9 months in that population. Median survival is 18 to 24 months. So that is a population actually that does very, very poorly. And it's also clearly an unmet need. So there are several trials that have been focusing on that patient population, asking a simple question. Does early immunotherapy in that setting, single agent treatment, make a difference in terms of survival? And so there are 3 studies that have been proposed. 2 are up and running. So the first one is the atezolizumab trial. Straightforward randomization between atezolizumab as a single agent versus surveillance, which is standard of care. And that trial is already accruing. The second trial is slightly different in design, same set of criteria coming into the patient population in terms of eligibility. It's still the persistent muscle-invasive patients, and the patients have nodal positivity after neoadjuvant chemotherapy. And both trials will also include patients who did not have neoadjuvant therapy but have high-risk features as well, T3 or N-positive disease. And in that trial, it's nivolumab versus placebo. And so the schedule is different, obviously, because nivolumab is an every 2-week therapy. And then there's a third trial that's been proposed in the intergroup mechanism, and that trial is looking at pembrolizumab. Exact same population in terms of those that receive neoadjuvant therapy, persistent muscle-invasive or greater disease, or those who didn't have it and have T3 or N-positive disease, and that's going to be pembrolizumab versus surveillance in that population. So that's the perioperative immunotherapy on the adjuvant side. Then we have the neoadjuvant setting, and as we know, cisplatin-based chemotherapy is the only therapy that confers a survival advantage in this setting, in the neoadjuvant setting. But there are a number of patients who are not eligible for it. And so what do you do in a patient who is cisplatin-ineligible? And so now that space is being tested in terms of therapy. So there's a durvalumab plus tremelimumab trial in that space. There's actually also nivolumab and ipilimumab trial in that space. We're going to see more of those. And the question is going to be not just response. What we know from all the studies so far is we can see rapid responses. The question is going to be the durability of response, post surgery, et cetera. And I think we as academicians are going to have to try to figure out how do we measure that in terms of surrogate endpoints as well.
Well, as we've seen in the SWOG data with neoadjuvant MVAC, if you have a pathological complete response, you have an 85% chance of being disease-free at 5 years. So the PCRs may not be seen with these patients. You may see a downstaging, but not, so it's going to force us to rethink how we look at this particular disease. So upper tract disease, are these included in these trials?
So yes, in terms of for example, the nivolumab trial, patients who have high-risk upper tract disease, they are eligible for trial. Same thing with atezolizumab. I think that cohort is
it's actually already
accrued. Exactly right. And so we will have those there. Yeah. There's a question as to whether upper tract disease might be more sensitive. We've sort of kicked that can around a little bit because more Lynch syndrome patients, more MSI, potentially a higher response rate. So we'll get a readout with regard to that, with regard to these trials.